Hello, everyone. Welcome to this lecture about seizures and epilepsy. My name is Haytham Tayyib. I'm a neurologist, epileptologist, and assistant professor at King Abdulaziz University. And we can start this lecture by the definitions, because as you notice, the lecture was called Seizures and Epilepsy. It wasn't called seizures and it wasn't called epilepsy, because there's an important distinction between the two. A seizure is an event that is characterized by abnormal neuronal discharges in the brain, and these produce and result in behavioral clinical manifestations, whether motor or sensory or behavioral, psychiatric, or cognitive. So there are several important parts of this definition. A seizure is an event, which means that it has a clear beginning and a clear end, and it lasts a defined, typically short duration in time. It is not something that's prolonged. A seizure typically lasts anywhere from a half a minute to 2-3 minutes, usually, and most seizures end by that time, unless there is the event is prolonged and you have something we call status epilepticus. We can talk about that later. So a seizure is one type of neuronal behavioral of neurological spells that you can see. There are TIAs, there are episodes related to vertigo and dizziness and psychiatric episodes. There are all kinds of causes for neural alteration in awareness or alteration in consciousness or episodes of abnormal movements, and seizure is one cause of such neurological spells. بمعنى a seizure is type of نوبة بالعربي فلها بداية ونهاية محددة. The other component of the definition is that it results from abnormal discharges in the brain, and that means that there are neurons that are firing abnormally and oftentimes firing excessively in the brain in an abnormal way. And these discharges lead to behavioral manifestations. Seizures are can be motor, sensory, or psychiatric, or autonomic, and can have variable combinations of manifestations. Although typically in one patient, the seizures are stereotyped, which means the seizure is always the same, having the same phenomena, the same we call semiology, or the same symptoms every time it comes. It produces the same symptoms, which we call stereotypes. Seizures are stereotyped events. All right. So now, what is epilepsy? Epilepsy is the tendency or vulnerability to have spontaneous seizures occur in the brain. So when a brain is abnormal in a way that makes it have seizures every now and then over the course of months or years, without any external apparent cause that provoked it into having seizures, only then can we say that this person has epilepsy. So we need to have unprovoked seizures. And the question becomes is, what are provoked seizures? Provoked seizures is when you have a seizure because of things like, say, trauma, acute head trauma, or say hypoglycemia, or acute seizures in the context of CNS infections, for example, or brain hemorrhage, and so on. Many conditions that relate to acute neurologic injury can cause seizures acutely. So, for example, you can, if your glucose goes low, you may have a seizure. If your sodium goes low, you can have a seizure. If your urea is high, you have renal failure, and you're hyperuremic, you can also develop seizures. But when you fix these conditions, people will no longer be at high risk of having seizures. when we call seizures in those situations provoked seizures. In epilepsy, the brain is inherently, by itself, vulnerable to producing abnormal neuronal discharge. So take a person with trauma, for example. If this person with trauma had a seizure right after the trauma, you would call this a provoked seizure. Whereas if the person had a seizure 6 months or a year after the trauma without an apparent reason, you would say, well, the trauma changed this brain in a way that makes it vulnerable to having seizures despite there not being a provoking factor. We typically say that we require more than one seizure to make the diagnosis, but if your brain, if the person that comes in with one seizure has an abnormal brain or an abnormal EEG, we may also diagnose the person with epilepsy. Are there events that cause outward behavioral manifestations without abnormal neuronal discharges? Yes, an example of these is non-epileptic seizures, and these are events that cause shaking and maybe other behavioral manifestations without the presence of neuronal discharges, and that's one of the type of non-epileptic events that can take place. And I mentioned already other things like TIAs, for example, or vertiginous spells related to vestibular dysfunction, like ear problems, and low blood pressure can cause syncope, for example, palpitations, maybe a marker for cardiac arrhythmias. So all of these are in the differential diagnosis of paroxysmal spells, paroxysmal neurological spells. All right, so now that we nailed some of the definitions down, we can discuss this a little more. We said that provoked seizures are related to acute injury of the central nervous system. I already gave you examples of those. And by the way, up to 10% of people that you know or have seen will have a seizure in their lifetime at least once. Not all of them will have epilepsy, but they may have one of any of these provoking factors. So seizures are not uncommon, and about 1 or 2% in the population actually have epilepsy. And it's not a disease for the young or the elderly. It has a bimodal distribution, so it peaks early in life and late in life. So it is one of the common neurological disorders, and it's very prevalent in society. All right, so we're going to talk about two things. We're going to talk about the types of seizures, and we're going to talk about the types of epilepsy. And the types of epilepsy depend on the types of seizures you have, as well as other factors. So let's talk first about the types of seizures. There are focal seizures and there are generalized seizures. Focal seizures start in a focus, what we call a focus, in one of the two hemispheres of the brain, whereas generalized seizures involve both hemispheres at onset, which means that there is really no particular focus in one hemisphere or the other. They involve both hemispheres very quickly, and hence we call them generalized seizures. And you are probably most familiar with what we call tonic clonic seizures. These are the seizures that often bring patients with epilepsy into the hospital. People fall down and stiffen and shake and can become cyanotic and bite their tongue and have urinary incontinence, and everyone gets really stressed out, and it becomes a dramatic situation. Tonic seizures is when a person just suddenly stiffens and does not shake. Tonic means stiffening, and clonic means shaking. So tonic seizures are seizures that only have stiffening in them. Clonic seizures are seizures with shaking, repetitive shaking of one limb or the other, or the whole body. Atonic seizures are a type of seizure where the patient suddenly loses tone and falls to the ground. Myoclonic seizures are sudden jerks that happen in the body, so one jerk or a couple of jerks. It's a sudden jerk that happens of the entire body or of two limbs. It's a sudden lightning-like brief jerk. And Epson seizures are events that are typically brief of basically loss of awareness without any other manifestations. And these can happen happen oftentimes in children and young adults. And those don't have any motor um, manifestations associated with them. And in all of these, during all of these seizures, your EEG, your electroencephalogram, will show abnormal neuronal discharge in both cerebral hemispheres and in all regions. All right, so those are generalized seizures. Now, the other type is focal seizures, and these are seizures that, like we said, that start in one focus in the brain. For example, in the temporal lobe, in the mesial temporal lobe, or in the mesial frontal lobe, and so on and so forth. And these are of two subtypes: focal aware seizures and focal unaware seizures. In other words, seizures that start focally, focal seizures, can happen with intact awareness. The person will be completely aware and will remember everything and might be able to tell you what they're experiencing, and so on and so forth. And or they may be unaware during the seizure with altered awareness, not necessarily comatose or with loss of consciousness, but they will be the person will have altered awareness and may very well not remember what's going on during this focal seizure. The older terms for these two types of seizures are simple partial seizures, simple focal or simple partial, and complex partial. All right, so what are the other symptoms? How do focal seizures manifest? And the answer is that it depends where the seizure originates from. So, for example, we know that there are several lobes in the brain. So if a seizure starts in the occipital lobe, right here, there will be an excessive function of that part of the brain, and the function of that part of the brain is vision, so you will have visual hallucinations, for example. So, and early on, the patient will be able to tell you, okay, the hallucination has started. I had a patient recently who had a hallucination of a round shape of colors that comes to him and lasts for a minute and then disappears. And then he can have this event 6 or 7 times during the day before treatment. So this would be a focal seizure of occipital origin, and it's focal aware because the person is completely aware. If the seizure starts in the parietal lobe, in the sensory area, the person will have sensory manifestations like a tingling. And if the seizure starts in the face area, it can travel to the arm area and then to the leg area in what we call a Jacksonian march. The seizure marches. And this tells us that the seizure is coming or is involving the sensory areas in the brain. And that's just how focal seizures are. The symptoms depend on where the seizure is originating from. Having said that, neither the occipital lobe nor the parietal lobe are the most common foci for focal seizures. The most common foci for focal seizures are temporal and frontal, and by far temporal is more commonly encountered. The temporal lobe kind of likes to have seizures. So let's talk about that in detail, because oftentimes people come into the emergency room manifesting with generalized tonic-clonic seizures, but these have often will often be have been preceded with focal seizures. And those people don't talk about those because those are not they're oftentimes quiet and they don't cause a lot of the distress to the family or to the people who are around the patient. As a matter of fact, the majority of seizures that happen in the world are, what do you think, focal or generalized? They are indeed focal seizures, with an estimate of about 70% of people of seizures being focal and up to 20 or 30% of seizures being generalized. And many of the generalized seizures that you see, like I said, will have started focally, either focal aware, progressing to focal unaware, and then progressing to generalized seizures, or starting with focal unaware and progressing to generalized seizures. All right, so what are the manifestations of temporal lobe seizures, and what are the manifestations of frontal seizures? Let's talk about that. Or let's observe this video first. So this is the seizure that often brings the patient to the emergency room. This person was already admitted. They are stiffening. This is the tonic phase. You can see his family member putting him on his side in order to avoid aspiration. You can see that they're starting to have the clonic phase. So this is the tonic-clonic seizure. This is the generalized tonic-clonic seizure. And we're still in the clonic phase, and very soon it will finish. As you can see, this barely lasted by the time it finishes, it will have lasted a minute or so, and so on. So this is what you may have seen, and this is what people will talk to you about, the generalized tonic-clonic seizure. But very often, patients come in will have focal symptoms before they have this. If their seizure had started in the temporal lobe, their symptoms will depend on which parts of the temporal lobe the seizure involved at onset. We think of the temporal lobe as being mesial or medial and lateral. So if you remember, there are important structures in the mesial temporal lobe. So let's say we'll take a lateral version, a mesial view of the brain. This is the corpus callosum here, more or less. And you will remember that there is the hippocampus and parahippocampus around this area, and then there's a structure called the hippocampus, and the hippocampus takes we just talked about this a little bit in the or we will talk about this in the mental status examination. The hippocampus is involved in the circuit of Papes that is important for memory, and in front of the hippocampus, there's what we call the amygdala. So this is the hippocampus, and this is the amygdala. And the amygdala is involved in emotions like fear and anxiety and depression, and has a lot of psychiatric and psychological functions. And also in the tip of the temporal lobe, there's what we call the uncus, and this area is important for olfactory for olfaction, and therefore the symptoms of mesial temporal seizures are, if you involve the amygdala, you'll have fear, you will have emotional manifestations. People may start yelling, asking God for forgiveness or for help and so on, because people can feel suddenly really, really scared. And because the hippocampus is involved, you can have abnormal memories. People will feel like they remember the place they're in, even though they weren't, even if they weren't in it before, which is what we call deja vu, or what we call jamais vu, which people will be at their home and suddenly will feel that their place feels distinctly unfamiliar. And people with epilepsy will have these, may have these symptoms as part of their mesial temporal seizures. Um, the temporal lobe, in addition to its important function in memory and emotion, has important links to basic motor functions and basic autonomic functions. It's the lobe that helps you eat and conduct um, your basic biological functions and so on. So it is connected to the basal ganglia, and it generates automatic movements during eating and during searching for food and so on and so forth. So therefore, when the temporal lobe is involved and the seizure spreads to the basal ganglia, we can have what we call automatisms. And automatisms are semi-purposeful movements. It will look like someone is doing something, but in fact they're not doing it, and the movements are involuntary. And these movements include lip smacking, which is as if someone is chewing or is pursing their lips outwards, and it may look like they're moving their hands repetitively, one or two of their hands repetitively, as if they are searching for something. And like I said, the temporal lobe is connected to the autonomic system in the hypothalamus. So people may have gastric sensations, an epigastric rising sensation. People will tell you that they suddenly feel something rising in their stomach. I just had a patient with this experience today. People may have tachycardia, and their nose may drip, so they will raise their hand and wipe their nose. And when there's spread to the basal ganglia, people may have dystonia, which is sustained contraction of one hand or the other. And if you notice these things during this seizure, people will be maybe staring and they will be quiet. It's a quiet type of event. Someone will stare and start chewing and maybe moving their hand a little bit, and they may or may not be able to tell you that the event is starting. So these are the manifestations of mesial temporal seizures. What about lateral temporal seizures? So let's take this brain and let's flip it, and we'll talk about what's on the other side of the temporal lobe. So this is that didn't come out quite right. Let's fix it a little bit. Um, Temporal lobe was a little smaller than it should be. In any case, the frontal lobe, I mean. In any case, so this is the Sylvian fissure. This is the premotor gyrus, and this is the postmotor gyrus. And here we have the hearing area, and we have the Wernicke's area. And so we have hearing, language, understanding of language, and we also have, if this is the occipital lobe, and this is where we see, then the secondary visual areas reside here. So secondary, higher order visual processing. So the manifestations include um, difficulties with comprehension. People may have an aphasia, auditory hallucinations, and they may also have formed visual hallucinations, which means they may see actual animals or humans. So I had a patient today who had, every time she had her seizure, she saw a picture of a man on one side uh, before she continued to convulse afterwards. So this is in contrast to occipital seizures where people will have unformed visual hallucinations, like the other guy I told you about with just a ball of colors, whereas this person has a hallucination of a man. And after temporal lobe seizures, people will be confused for maybe 5-10 minutes. People will certainly be confused after a generalized tonic-clonic seizure as well. This is what we call the post-ictal period. All right, so what about frontal seizures? Let's remove all of this stuff so that you can read. Frontal seizures are different a little bit. So people will have behavioral manifestations. They may be agitated because we know the frontal lobe is responsible for behavior. People may also have speech arrest because Broca's areas is there, and if function of Broca's area is impaired, people will not be able to speak. The motor system is there, so people can have hyperkinetic movements, which means large amplitude, really dramatic movements, and the frontal seizures are often brief and they're often not preceded by a post-ictal confusion. So you can already notice a difference between temporal and frontal seizures. One is quiet and relatively longer, and one is kind of not quiet. People can have agitation and have a lot of behavioral symptoms, a lot of motor movements, and they will be short. The other thing is that they often happen at night. Temporal seizures can happen at night, but frontal seizures very often happen at night. So if you have a short, abrupt, dramatic event that happens at night, it's most likely frontal and not temporal. All right, so we talked about. So notice that this is the same patient that you saw earlier, and this was how he was before he had his convulsion. So he seems to feel something, and if you notice that he turned his finger, telling his wife that he's not feeling well, and that he's starting to feel strange. And at this point, he's probably starting to have a seizure of the simple focal type. Look at his right hand. If you look here, you'll notice that his right hand is performing a picking movement. This is the automatism. Look at his mouth, and he's kind of chewing and lip smacking. So you think this is a mesial temporal seizure, a lateral temporal seizure, or a frontal seizure? If you said mesial temporal, then you are probably, then you are right. And now the person is starting to generalize and go into the convulsion that you saw earlier. So it is very important that when people come to you in the emergency room with a convulsion, you ask if they felt something before the seizure. This is what people call the aura or the warning. مقدمات النوبة أو النوبات الصغيرة, because النوبات الصغيرة do not always progress to convulsions. You need to ask whether people have different types of spells and whether these spells, the big spells, are preceded by smaller spells. All right, so That's the first thing you want to determine, whether people have focal seizures or generalized seizures. Subsequently, depending on the types of seizures that a patient have and depending on their age and what their testing shows, people will have either focal epilepsy or generalized epilepsy. And it's important to distinguish between the two because as you expect, the treatment is different. So in focal epilepsy, we can offer them. We offer both, obviously, anti-seizure medications, but in people with focal epilepsy, if they are refractory, we can offer them surgery, whereas people with generalized epilepsy, we can offer them different surgeries if their epilepsy is refractory. So people with focal epilepsy will have focal seizures, and they may or may not have generalized seizures, whereas people with generalized epilepsy will only have generalized seizures and will not have focal seizures. And each of these focal or generalized epilepsies can be either genetic due to an abnormal protein encoded in the neuronal membrane, causing the neurons to be hyperexcitable, for example, or there may be a genetic abnormality causing certain proteins or polysaccharides to be deposited in the brain, causing the neurons to be hyperexcitable, and so on. And they can also be acquired, and by acquired, I mean secondary to some sort of injury, like we mentioned the person who had a trauma as an example earlier on. So any cerebral injury can cause epilepsy, and if it happens in a particular part of the brain, it causes a focal type of epilepsy, and if the injury is diffuse, it can cause a generalized type of epilepsy. It will be an acquired generalized epilepsy. One very common type of acquired focal epilepsy is mesial temporal lobe epilepsy due to hippocampal sclerosis, and this is a condition where the hippocampus that we talked about earlier appears to be atrophic for one reason or another, and it may relate to having a lot of febrile seizures during childhood, or may relate to difficulties at birth, or one of many other reasons. There are also benign tumors that happen in the mesial temporal lobe, and these can also cause focal epilepsies. If you have a stroke in any part of your brain, you can also have a focal epilepsy secondary to that. All right. So I want you to ask yourself, would you be able to know if you saw someone next to you staring, not responding to you, and like the video we saw, would you be able to know what seizure that was? And I want you to think, are focal seizures potentially dangerous for you? So if someone has only focal seizures, they stare, they chew, they pick their hands, and they don't have generalized seizures, will you want to treat them or not? The answer is yes. I have a patient who she was bathing her baby, she was washing her baby, and she almost let the baby um, uh, fall out of her hand when she had a focal seizure. Luckily, the baby did not die or drown, but you can see how focal seizures, they last 2-3 minutes, but they can be the worst 2-3 minutes in someone's life. If someone crosses the street and they have a focal seizure and are confused, or if they're driving and are confused, then dramatic and negative consequences may occur. So yes, focal seizures are definitely worthy of treatment and they need to be recognized. All right, watch this video and tell me what kind of seizure it is. This person is sleeping, and then suddenly this. She woke up, She is turning in bed, she's kicking a lot, and it's about to stop, and it lasted for less than 30 seconds. So was this a quiet event or was it a dramatic event? Was this 2-3 minutes or was it 30 seconds? And if you look at her, does she seem confused or is she, well, it's not fair to ask you. I will tell you that she is not very confused after this. So ask yourself, is this a focal seizure or a generalized seizure? Is it a generalized tonic-clonic seizure, tonic or atonic seizure, or myoclonus or absence? No, it doesn't look like any of those. Is this a focal seizure? Probably. Focal seizure that is temporal or frontal. If you go back to the uh, table that we talked about a little while ago, you will answer frontal seizures because it happens at night and it's brief and it has this abruptness to it with bicycling movements of the leg and a little bit of agitation and so on. You see how large the amplitude are, whereas the patient that you saw convulse and you saw have a focal seizure earlier had a relatively quiet seizure before they convulsed. All right, so what do you do when you get a patient with seizures? You need a detailed medical history. And the medical history of a patient with epilepsy starts basically from before conception. So you want to ask about whether they were full term or preterm, whether the pregnancy was complicated or not. So all your perinatal history is important, whether the person was born normal or C-section, because all of these are risk factors for development of brain injury early in life that later on causes epilepsy. You want to ask if the patient had birth anoxia, and if they had any form of developmental delay, because that can tell you that the person may have had an abnormal brain growing up. And you ask if they had any serious brain injury like a meningitis or an encephalitis, because that puts you at later risk of epilepsy. And you can ask about head trauma as well at any time in life. So all of these are epilepsy risk factors. And then you want to ask about the event itself, the paroxysms, the seizures. You want to determine the seizure types. So like we said, you want to ask about the aura and then the actual event, if there was motor or sensory or autonomic, or there were psychiatric manifestations. And then you want to ask about post-ictal symptoms after the event stops. What happens? Does the patient have weakness on one side or the other? Is the patient confused? If the patient is confused, you know that they didn't have Epson seizure, for example, and they're more likely to have a focal seizure or a temporal lobe, for example, or a generalized tonic-clonic seizure, for example. If they have weakness on the right side, then you know the seizure originated from the left side, and the left side seized for a longer period of time. So it is important to know what happened post-ictally in order to determine the seizure type or the seizure types. Okay, so oftentimes you'll have someone come here to you with a convulsion, and you will want to ask clearly and carefully about whether there were partial seizures or focal seizures before that. إذا كان في نوبات دوخة أو إذا كان في نوبات خوف أو إذا كان في أي مقدمات للconvulsion. You want to ask about what happens after, and you want to ask about what happened earlier in life and if there are epilepsy risk factors or not. And family history, by the way, is one of the things you want to ask about because there are, especially in genetic epilepsies and genetic generalized epilepsies, there may be family history. All right, so you want to take a detailed history when patients come to you. And then what you want to do is perform one important point that this slide mentions here is that you have to ask a witness, because sometimes people with focal unaware seizures or generalized seizures will be unable to tell you. In fact, if you have a generalized seizure with bilateral shaking, that patients remember and tell you clearly what was happening and tell you that they remember everything that was happening around them during shaking, and that event is probably not of epileptic origin and maybe of psychogenic origin. So people oftentimes do not remember what happens during a seizure. Therefore, you want to ask witnesses. You perform a physical neurological examination to look for a cause. If someone has a stroke, you may find upper motor neuron findings on that side. If someone has meningitis, or has had meningitis, you may find clinical signs that clue you in for that diagnosis and so on. You might want to get an EEG that helps you determine the seizure type and helps you determine if a patient is continuing to have seizures. And you want to get imaging of the brain, either CT of the head, and most often brain MRI is the investigation required in people with epilepsy. The EEG helps you determine, can show you interictal changes, changes between seizures, which means that you don't necessarily have to have an abnormal EEG. Only 40 to 50% of people with epilepsy will show you abnormalities in their EEG interictally between the seizures. And what we do is we repeat the EEG several times in order to try to prove the diagnosis. But epilepsy is a clinical diagnosis, and EEG only helps you determine the seizure type and can help you prove the diagnosis sometimes. So if you look at this EEG here, just for your knowledge, it shows the spike of activity here in a part of the brain, not all of the brain. So it's evidence for focal epilepsy. This here is another EEG showing spikes or discharges, which with evidence of focal epilepsy, because it's coming from these two channels and not the other channels. Whereas if you look at this one, you can see spike and slow wave activity happening in all of the channels. So this is evidence of a generalized epilepsy. And we will not show you any EEG during the exam. It's just to show you or to teach you that EEG, what the role of EEG in the diagnosis is, that it helps prove the diagnosis of epilepsy sometimes, but if it's normal, it does not rule the diagnosis out, and it helps you determine the type of epilepsy sometimes. And it can also help you capture the seizure. What we saw earlier were interictal changes. This is an EEG showing the changes during the seizure, the ictal EEG. And again, I will not ask you to read EEGs, but these rhythmic slow waves that are happening in this part of the brain are not happening here. This is how a seizure looks like, and it progresses, becomes faster, and it involves only one side of the brain. So this is a person with temporal lobe epilepsy. So the MRI is a test of choice because it shows you small abnormalities that are often the cause of the patient's epilepsy. The mesial temporal sclerosis that we talked about earlier is oftentimes only visible in brain MRI, and this is an example. So if this is your temporal lobe, and this is how a normal temporal lobe looks like. There's a little bit of atrophy, but that's fine. This is the hippocampus that we talked about, and you see that it goes up and down. That's the normal hippocampal architecture. But look at the other side, it's a little whiter, and it's flattened, and the CSF space around it is bigger, and this is what we call mesial temporal sclerosis. And in fact, this person was refractory to medications that we gave them, and what we ended up doing is we ended up doing a temporal lobectomy on them and they became seizure-free. And that's the goal of treating epilepsy. Let's talk about treatment. The goal is seizure freedom. We don't want people to have any seizures. We do not accept a seizure a month. We do not accept a seizure every 2 months because seizures are dangerous and they negatively affect and impact the quality of lives of patients. So we strive to get people to be seizure free as much as possible. Uh, and we do not accept side effects of anti-seizure medications, so we always strive to choose the best regimen for the patient. And epilepsy has a lot of social and professional implications potentially and effects on the quality of life. And it is important to make sure that the person's quality of life and professional life and family life are not affected by their epilepsy. So you have to always ask patients about their life and not just whether they had seizures or not and what their medication doses are. If a person has one seizure, are you going to treat them? If a person had a provoked seizure, like they came in and they had a low blood sugar, all you need to do is fix their blood sugar and you don't need to treat them. But what if a person had unprovoked seizures? Their glucose was normal, there was no head trauma, there was no infection, etc., and they were otherwise healthy. What you do is you examine them and you get a brain MRI and an EEG, and if the EEG is normal and the brain MRI is normal, and there are no apparent risk factors for epilepsy, what you do is that you do not treat because the risk of recurrence is typically uh, 15 to 20% or so if the EEG is normal and the MRI is normal and the exam is normal and there are no risk factors, then your risk of having another seizure is only 15 to 20%, which means you can treat 5 or 6 people for a long period of time and they will not have had another seizure even if you didn't treat them. If one of these is abnormal, then you can consider treating them because that elevates the risk to 40% to 50%. Sometimes we treat people with single seizures anyways, if they had dangerous jobs or if they really wanted to make sure that they have the best chance of being seizure free, then we treat them. But these are exceptions, and generally speaking, what we do is we do not treat first seizures if they were with normal EEG, MRI examination, and no risk factors. Let's say you decided to treat them. Someone came in with several seizures. You diagnosed the epilepsy. You determine the type of the epilepsy. You start a medication. You start one anti-seizure medication. And in 70% of the situations, you will achieve adequate control with the first seizure medication that you choose, which is really great. You can't say that in many other conditions in medicine. A carefully chosen first anti-seizure medication will basically render your patient seizure-free. In 30% of people, you will need to add another medication or change the medication or use 2 or more medications, and you will help a bunch of them, 15%, but 15% will be refractory to medications. So if you try 2 or more medications, you can label this patient as treatment or medication refractory epilepsy, and then you can consider epilepsy surgery if it fits the patient's profile and need. All right. How do you choose your first anti-seizure medication? It depends on your type of epilepsy, it depends on the age of the patient, and it depends on the other drugs that the patient takes. So you want to tailor your choice depending on the patient profile. So let's go through this a little bit. Um, so there are older anti-epileptic drugs and there are newer anti-epileptic drugs. The older agents are often sedating, like something like phenobarbital, for example, is really sedating. There is a coma called phenobarb coma because the medication is quite sedating. And that goes for most of the older anti-epileptic drugs like phenytoin, carbamazepine, and so on and so forth. Most of these are sedating. They also cause a lot of drug-drug interactions. They induce enzymes, and this can cause problems if someone is taking warfarin, for example, and they want to have an INR level of a particular number, and then you start them at enzyme-inducing agent. Their INR can be lower, then they can have vascular events because of that, and so on and so forth. The older agents are also toxic to the bone marrow, so they can cause osteoporosis, they can lower vitamin D level, they can cause fractures, and so on and so forth. And there's a risk of hypersensitivity and rashes with these agents as well. There are more than 25 or 30 anti-epileptic medications. Nowadays, there are a lot of newer agents that are better in these areas, but they persist in having behavioral side effects. So some of these medications cause a little bit of depression or anxiety, and sometimes a lot of depression or irritability or even suicide, rarely. Um, and But they are much more tolerable than older agents and easier to use. You don't need levels and you don't worry about drug-drug interactions, but they are of course more costly. And You want to choose you want to, before having, after having this perception of what different classes of antiepileptics are, you want to consider the person's epilepsy type. In partial epilepsies, focal epilepsies, uh, basically all medications work. All anti-seizure medicines can work. But there are medications that specifically work best in partial epilepsies. These are carbamazepine, oxcarbazepine, and these are the ones listed here. In generalized epilepsies, you want to avoid these medications, and you can use these medications: the Levitor Acetamine, lamotrigine, topiramate, zonisamide, valproic acid. Okay, and if the first agent doesn't work, you can resort to one of these subsequent agents, for example. So what you need to remember, a rule of thumb for this slide is for focal epilepsy, you can use any medication, but these ones work best, and these ones you avoid in generalized epilepsies. All right, what's next? So then you consider the patient's profile. So if the patient um, has a particular vulnerability to a particular side effect, you try to avoid that side effect. So you want to know the side effects of the different anti-epileptic drugs so that you can choose the correct agent. So for example, um, someone who's a medical student like you trying to study and focus and concentrate, you don't want to give them topiramate because it is notorious for causing cognitive impairment. If someone is overweight and they want to lose weight, then you give them topiramate because it causes weight loss. Um, and that can be a favorable side effect. If someone has glaucoma, you don't give them topiramate, and so on and so forth. If someone has bipolar disorder, for example, or headaches, you give them valproic acid because it is a mood stabilizer and it's a migraine prophylaxer. But if that person was a woman in childbearing age, you do not give them valproic acid because it causes weight gain and it's terribly teratogenic. And if that woman gets pregnant, she can have a baby with a neural tube defect, and that can be a disaster. So what I want you to do is, not just in this slide, it's in your book. You can see there are dots here. There's a long list of side effects for each of the agents, but I highlighted some of them here for you. You want to know the side effects of each of these medications. So you want to know that phenytoin causes gum hypertrophy. It causes a rash. You want to know that carbamazepine can cause well, carbamazepine. All of these medications are potentially hepatotoxic, particularly valproic acid. One peculiar thing about carbamazepine that's not mentioned here is that it can cause hyponatremia, and that's something that can be terrible in the elderly. Levitor Acetam has become a widely used medication because of a uh, short list of side effects. The major side effects that we notice in, say, 10% of patients is irritability and anxiety, but it's oftentimes a very well tolerated medication. All right, Ethosexumind is a medication that only works for Epsons, only Epson seizures. It does not protect you from any other type of seizure. Um, and I want you to remember that lamotrigine causes skin rash and sometimes causes Stevens-Johnson syndrome with a dangerous rash that can kill people. And it is rare, but that is something that makes us start lamotrigine very slowly. All right, so during pregnancy, it is very important that you must continue anti-seizure medicines if your patient has epilepsy. Continue AEDs. Some people stop AEDs because there's a risk of teratogenicity, but then what they will do is that they will injure the mother and the baby they were trying to save, because if their mother goes into status epilepticus because of cessation of AEDs, both she and her baby will be at risk. So we must continue AEDs. We must make sure that we reduce the risk of teratogenicity because of anti-seizure medications as much as possible. So we choose the right medications and we follow the levels properly. Um, so the medication that we should completely avoid is valproic acid. And we should also try to avoid using too many medications as much as possible. And the best medications for this purpose are levetiracetam, carbamazepine, lamotrigine, and gabapentin. These are associated with incidence of teratogenic malformations that's almost equivalent to the normal population, which is 2 to 3%. All right, so you can look here and you can see gabapentin, lamotrigine, levetiracetam are down in the list. And do not use carbamazepine in childbearing age women. This is a recommendation from the International League Against Epilepsy. It's an international recommendation, and I keep repeating this because I see this very often done in practice, and I wanted to stop. So, and I'm hoping that you guys will be the ones not to use valproic acid in women with epilepsy as long as you can avoid it. We use it sometimes, but it is definitely our last resort. And if you have a patient with epilepsy, you need to make sure that you plan their pregnancy. You tell them that if they want to get pregnant, they come to you so that the pregnancy is planned and they don't get pregnant on a medication that is potentially teratogenic. And you have to remember that the oral contraceptive pills that some women take to prevent pregnancy are affected by medication by enzyme inducers. So these medications can lower the level of contraceptive agents. So if someone is taking phenytoin, for example, they have epilepsy, they come to you, you give them phenytoin, they were taking an oral contraceptive agent. Your phenytoin will reduce the level of the oral contraceptive agent. This will make them get pregnant, have a baby with a teratogenic malformation because phenytoin is teratogenic. The mother will be upset, the baby will be dead, and you will potentially go to jail. So you have to be careful which medication you choose when you have a woman with epilepsy. All right, so you determined the type of epilepsy and types of seizures. You chose the right medication after you considered the side effect profile of the medications you chose. Uh, like I told you, 30% of people will not respond to your therapies, and some 20% of them may be amenable to surgical treatment. We know that 60 to 70% will respond to the first medication. You will help 10 to 15 more by adding another medication, but the rest of the people will be maybe refractory. So if you choose two drugs, it doesn't really make a lot of sense to try a third and a fourth and a fifth, or to change too many times, and you need to refer this patient to someone with expertise in considering other options in treating epilepsy. This is what I just said. And that's a picture. That's the same MRI I showed you earlier with a temporal lobectomy, and this person until today is seizure free, and that's 2 years on. All right. So the last thing is status epilepticus, and which is prolonged seizures, and this is a dangerous condition, especially convulsive status epilepticus, which is prolonged convulsions. And by prolonged, we don't mean an hour, we mean 5 minutes or more. And as a matter of fact, any convulsion that lasts for more than 3 minutes should make you anxious. Um, and just like in stroke, time is brain, here also time is brain. We have to stop status epilepticus, you have to stop seizures as early as possible because seizures hurt the brain. They are caused by brain injury, but they also cause brain injury themselves. So we have to stop status epilepticus as quickly as possible. Especially convulsive status epilepticus, where people continue to have convulsions for prolonged periods of time. But there are also non-convulsive uh, seizures that we also need to stop and are associated with morbidity and mortality. So this is what I told you. There's a high risk of morbidity and mortality. And what you do is if someone comes to you and they're seizing, you give them glucose and thiamine just in case they are deficient on or low on those. And then you start to give them anti-seizure medications and you run labs to see if there are provoking factors, and you manage other medical comorbidities. But what anti-epileptics do you give them and how do you start? This is how it is. The first stage is benzodiazepines. So you give Ativan 1 or 2 lorazepam 1 or 2 milligrams, for example, or you give midazolam or something like that, and you can repeat that times 2. If the person doesn't stop convulsing in front of you, you go to the second stage. This is 1. The second stage is you start an anti-seizure medication, either fosphenytoin, for example, or phenytoin, or valproic acid. You can use any of these, valproic acid or Levitor Acetamine. They're all basically the same. And if your patient does not respond, you can start another anti-seizure medication along with that. But very quickly at this stage, you are calling ICU in order to intubate the patient and protect their airway. And if that doesn't help, if that doesn't work, this doesn't work, this doesn't work, you are quickly calling ICU to intubate the patient and start general anesthesia in order to stop the patient's seizures. So first step or first line is benzodiazepines. Second line is one of these anti-seizure medications. If they don't work, you are starting phenobarbital as another agent, but you're immediately calling ICU to make sure that they come in and intubate the patient in order to stop their seizures. All right, hope that was good. We will have a live session with cases to discuss and videos to watch and so on. And I'll see you then. Good luck.